Hi everyone, this is an informational video about medicinal chemistry. Hope you guys like it.
Hello? Are you into me like I'm into you? Do you wanna do the things I wanna do with you? You're so close and yet so...
Hi guys, as you can see from the title of the video, today we're going to talk about medicinal chemistry. But before we start, I would like to introduce to you guys what is medicinal chemistry all about. So, medicinal chemistry deals with discovery, design, development, and both pharmacological and analytical characterization of a drug substance. These disciplines combines with the expertise of a chemist and also a pharmaceutical industries to identify and also synthesize a reactive chemical agents that have a therapeutic use that we can use to put inside a drugs that give us benefits nowadays. So before we take into a deep look of our drugs today, which is allopurinol, I would like to tell to you guys, in these drugs industries, we have a good drugs and a bad drugs. So what is mean by good and a bad drugs? A bad drug is a drugs that when we taken them, it will give us a bad side effect to our body, such as ecstasy, cocaine, and many more, which is bad for our health. But a good drugs, when we taken them, it can cure our disease that we are suffering. So examples of a good drugs is paracetamol, which is used to treat fever, ibuprofen used to treat inflammation, and prednisolone used to treat nephrotic syndromes. But we must always bear in our mind all drugs that we taken inside our body can have a good side effect and also a bad side effect. So a bad side effects can cause some severe causes such as death when we taken it overdose. A good side effect is can cure our illness inside our body when we taken them. So one things that I want to share with you guys, such as this drug is a good drug, but it can transform into a bad drug when we taken it too much, such as sleeping pills. We know that when we take sleeping pills, it can help us to sleep well during the night. But if we take more than a prescribed dosage, it can cause poison inside our body and can kill us. So this is an example of a good drug initially, but transform into a bad drug when we take an overdose. So when we take our drugs, we must always remember that never take it overdose because it can cause poison inside our body. Allopurinol is a drug used to treat gout and also certain disease of kidney stones. This drug is usually used inside a chemotherapy cancer patient because inside their body, the uric acid level is increased due to the dying cells of the cancer cells. And by taking allopurinol, this uric acid level can be reduced. Okay, let me tell to you guys the chemical names of allopurinol. It is a long name. So it is 1,5-dihydro 4H pyrazolo 3,4-D pyrimidine 4,1. It's a long name, right? So this allopurinol is usually orally taken inside our body. So one tablet of allopurinol usually is white in color, and also it contains 100 milligrams of allopurinol and other inactive ingredients such as cornstarch, lactose monohydrate, magnesium stearate, povidone, and also purified water. So allopurinol usually prescribed by the doctor, not more than 800 milligrams of a dosage a day. So usually for a gout patient, the doctor will give 100 to 200 milligrams a day. And for a uric acid level patient, it's a little bit high. which is 600 to 800. And for the kidney stone patient, usually is 200 to 300 a day. Remember what I just said before? Overtaken of a prescribed dosage by a doctor is bad for our health. So, to know more about the allopurinol history and developments, therapeutic effect, pharmacokinetics, side effect and precaution, let's continue watching our video.
Okay, so for the history of allopurinol, something you should know about allopurinol is it was first synthesized and reported in 1956 by Roland K. Robbins in search for antineoplastic agents. This is because allopurinol inhibits the breakdown of thiopurine drug mercaptopurine. It was later tested by Wayne Randolph in collaboration with Gertrude Elyon's lab at Wellcome Research Laboratories to see if it could improve the treatment of acute lymphoblastic leukemia by enhancing the action of mercaptopurine. However, no improvement was tested by using the mercaptopurine allopurinol co-therapy. So then the work turned to other compounds and the team later started testing on the treatment for gout. Allopurinol was first marketed in 1966 as a treatment for gout. So now I'll be touching on the development of allopurinol. It is now 8 years since allopurinol was first introduced for commercial distribution in England, and about 12 years since the first phase 1 human studies were carried out following several years of laboratory studies. Allopurinol, a purine analog, was developed originally as xanthine oxidase inhibitor, with clinical application for the reduction in uric acid formation. Example in management of Dalmatian bronzing syndrome. Extensions of use have included protection of hypoxic tissues from reperfusion oxidative injury and have recently been extended to the treatment of leishmaniasis and Trypanosoma cruzi infections. Allopurinol also has been widely used since 1963 to treat patients with both symptomatic and asymptomatic hyperuricemia. Nowadays, allopurinol, a xanthine oxidase inhibitor, is also commonly used for the treatment of gout. Allopurinol is a product of rational drug design. From 1942 onwards, Hitchings, Elyon and co-workers, they worked together in effort to introduce new anti-neoplastic agents, started to synthesize and evaluate potential antimetabolites of the purine and pyrimidine bases of the nucleic acids. Allopurinol was designed to be an inhibitor of xanthine oxidase, the enzyme that catalyzes the biosynthesis of uric acid. First, in leukemia patients, they first tried in leukemia patients, then it produced a marked decrease in plasma and urinary levels of uric acid. This effect suggested its potential usefulness in the therapy of primary gout. In 1963, Randles and other co-workers performed with great success the first clinical trial of allopurinol in gout. Later, it was seen that its metabolite allopurinol is equally active. Thank you.
Hi guys, what? You're asking me about the pharmacokinetics of allopurinol? Well, I think I'm able to answer your question. So, pharmacokinetics can be divided into 4 parts, which is absorptions, distributions, metabolism, and excretions. The first point that I would like to share with you is the absorption part of allopurinol. Allopurinol can be rapidly and extensively absorbed through oral administration. This is because the bioavailability for oral administrations of allopurinol reaches 80 to 90%, which is quite high. The time of maximum concentrations observed for allopurinol is 1 hour and 30 minutes, while for oxypurinol is 4 hours and 30 minutes. From here, we know that allopurinol just requires a few hours to metabolize to oxypurinol and reaches its maximum concentration. The initial effect of the drug would appear around 2 or 3 days after the drug administrations, where the peak effect of the drug would appear around day 7 to day 14 after the drug administration. Next is the distribution part. In animals, allopurinol can be found the highest concentrations in vascular tissue, blood, liver, intestine, and heart. The volume of distributions for allopurinol is 1.6 liter per kg. Since the protein bound for allopurinol is less than 1%, this means that allopurinol is negligibly bound to the plasma protein, which means that allopurinol can traverse through the cell membranes more efficiently. For the metabolism part of allopurinol, allopurinol can be metabolized to form its active metabolite, which is known as oxypurinol. This metabolism process takes place in the liver. Oxypurinol can be detected in the circulations within 15 minutes after the drug administrations, and the highest concentrations of oxypurinols in the plasma is within 1 hour and 30 minutes to 4 hours and 30 minutes after the drug administrations. It is observed that the drug remains in the elderly body for a longer period compared to the young adult due to the decline in renal function. The higher the metabolism rate, the less effective the drug is. Hence, a high concentrations of oxypurinols in the elderly body indicate that most of the allopurinols is metabolized and the drug is less effective to the elderly body. The last part is the excretion of allopurinol. It is observed that oxypurinol is eliminated by the kidney. Part of the excretions will also occur through the feces. Up to 80% of the allopurinols is recovered in the urine within 24 hours, and it exists mainly in the form of oxypurinol. Oxypurinol has a longer elimination half-life compared to allopurinol, so that the effect of the active metabolite can last for a longer period. And lastly, an extra information for you is that the total body clearance of the drug is 15.7 ml per minute per kg. Well, that's all from me. Bye!
Hi all, I am going to talk about the therapeutic effects of allopurinol. Allopurinol is a purine analog. It is a structural isomer of hypoxanthine, which is a naturally occurring purine in the body. After ingestion, allopurinol is metabolized to its active metabolite oxypurinol in the liver, which acts as an inhibitor of xanthine oxidase enzyme. Allopurinol is frequently used in the treatment of chronic gout. Now, let's see the mechanism of action of allopurinol. Allopurinol and its active metabolites inhibit xanthine oxidase enzyme that converts hypoxanthine to xanthine and xanthine to uric acid, the product of human purine metabolism. In reactions catalyzed by xanthine oxidase, the use of molecular oxygen as a terminal electron acceptor results in the generation of reactive oxidative species with an unpaired electron in the outer orbit. Allopurinol does not directly interfere with purine nucleotide or nucleic acid synthesis. The drug, however, indirectly increases oxypurine and allopurinol ribonucleotide concentrations and decreases phosphoribosylpyrophosphate pyrophosphate concentrations, thus decreasing de novo purine biosynthesis by pseudo-feedback inhibition. In addition, allopurinol increases the incorporation of hypoxanthine and xanthine into DNA and RNA, thereby further decreasing serum urate concentrations. Allopurinol may produce a deficit of total purines amounting to several hundred milligrams daily. Accompanying the decrease in uric acid produced by allopurinol is an increase in serum and urine concentrations of hypoxanthine and xanthine. Plasma concentrations of these oxypurines, however, rise commensurately with the fall in serum urate concentrations and are often 20 to 30% less than would be expected. This discrepancy occurs because renal clearance of the oxypurines is at least 10 times greater than that of uric acid. In addition, normal urinary purine output is almost exclusively uric acid, but after treatment with allopurinol, it is composed of uric acid, xanthine, and hypoxanthine, each having independent solubility. Thus, the risk of crystalluria is reduced. Alkalinization of the urine increases the solubility of the purines, further minimizing the risk of crystalluria. Decreased tubular transport of uric acid also results in increased renal reabsorption of calcium and decreased calcium excretion. Allopurinol also inhibits reperfusion injury. This injury occurs when organs that either have been transplanted or have had their usual blood perfusion blocked are reperfused with blood or an appropriate buffer solution. The cause of this injury is local formation of free radicals, such as the superoxide anion, the hydroxyl free radical, or peroxynitride. These substances are strong oxidants and are quite damaging to tissues. Now I am going to explain about the structure-activity relationships of allopurinol. Allopurinol is a bicyclic structure comprising a pyrazole ring fused to a hydroxy-substituted pyrimidine ring. It has a role as a radical scavenger, a gout suppressant, an antimetabolite, and a xanthine oxidase inhibitor. It is an organic heterobicyclic compound and a nucleobase analog. It derives from a hydride of a 1H-pyrazolol 4,3-D-pyrimidine. The active site of this drug is the carbon of the pyrimidine ring. As the active site, allopurinol is oxidized to oxypurinol, a strong competitive inhibitor that remains tightly bound to the reduced form of the enzyme. In addition to blocking uric acid production, inhibition of xanthine oxidase causes an increase in hypoxanthine and xanthine, which are converted to the purine adenosine and guanosine monophosphates. Increased levels of these ribotides causes feedback inhibition of amidophosphorybosyl transferase, the first and rate-limiting enzyme of purine's biosynthesis. Allopurinol therefore decreases both uric acid formation and purine synthesis.
The common side effects of using allopurinol are ankle, knee, or great toe joint pain, joint swelling or stiffness, and rash. The rare side effects include anxiety, constipation, coughing up blood, depression, diarrhea, dizziness, and so on. Sometimes, starting allopurinol can actually trigger an attack of gout. As the crystals begin to dissolve, patient will probably be given an extra medicine for the first few months of taking allopurinol to reduce the risk of these attacks happening. Most people who take allopurinol don't get any side effects, but if patients do have side effects, it may be possible to restart allopurinol using a special desensitization course. This involves beginning allopurinol at a very low dose and increasing the dose gradually. There are some tips or precautions that need to take note when using this drug. First, allopurinol may be better tolerated if taken with food. Second, if patients forget a dose of allopurinol, they do not need to double up the next dose. Just continue taking allopurinol as scheduled. Third, allopurinol is a maintenance treatment for gout or high uric acid levels, so it should be taken regularly even once a gout attack has resolved. Do not drive or operate machinery if allopurinol makes patient drowsy or impairs patient judgment. Ensure patient maintain a good intake of fluid while taking allopurinol. A fluid intake of 2 liters per day is recommended to reduce the risk of kidney stones developing. Allopurinol may increase the risk of developing a rash if patients take them with the antibiotics such as ampicillin or amoxicillin. Allopurinol may increase the effect of warfarin and other drugs that thin the blood. These are known as anticoagulants. As a result, patients may need to have blood clotting tested more frequently. Here are some responses after taking allopurinol. First, peak levels of allopurinol are reached within 1.5 hours and 4.5 hours for its active metabolite. Allopurinol may be taken once daily. Normal serum uric acid levels are normally achieved within 1 to 3 weeks. It may take 2 to 6 weeks before allopurinol effectively reduces gout attacks. It is not unusual to experience a gout attack in the first few weeks of allopurinol initiation.
That's all from us. Thank you for watching our video. Hope you guys have gained a lot of information about allopurinol. See you guys again. Bye.